Guys, I'm going to start out today's discussion with the topic of should you use belts if you've got back pain or sciatica. I'm talking about supported belts here. We had one of the questions on TikTok about this, and I know I get it all the time, about using these back braces to protect this lumbar spine, to make it a little less vulnerable, because they feel great. When you use them, they feel really good. I make no bones about it. But hopefully this will help you guys understand whether this is something that you should be using or you shouldn't be using, back braces for your lumbar spine, especially if you've got herniated discs. And we're talking, for most of you guys from the comments, it's going to be L5-S1, L4-5 sections of your lower back, and that is really important. L4-5, which is this green one here and this green one here, that's that segment. And then L5-S1, which is the green down to the orange. That is the section of the lower back that we are talking about. And one of the really important things I want you to look at here is where the iliac crest sits. That's these bits here, that's the sides here. If we start out with how a brace or support actually works on another joint, because this will help us, right? And I obviously had a very recent episode of knee trouble from the meniscus tears, and I used a brace during competition, a knee brace. Now, if I'd walked out and my coach, and I had the knee brace on, and I had it round my calf, my coach would have looked at me and said, Mike, what are you doing? That's in the wrong place. You haven't put it around the joint. What are you doing? And so the knee joint support ran across here. Across my knee joint line is here. It ran across my knee joint so that it could effectively provide that extra layer of stability to that region. What's more, I can actually control my knee joint, so I could also use some of the muscles to strengthen and support and provide a big degree of stability, and that actually really, really helped in many ways. But the point is that it's on the joint line. So when we look at the lower back, if we take the life-size model of the spine, roughly like side, let's assume the reality that more or less all of you guys have issues down here, L4-5, L5-S1. Assuming that you are like this guy here, a skeleton, and have no other tissue, 0% body fat, you might get the brace to start here at the level of the L4 vertebral body, the inferior portion, the bottom of it, right? And then the brace would stabilize this section here. Is that akin to putting the strap on the knee joint or down around my calf? It's the latter. And so even in the individual where we might well be verging on 0% body fat, we're probably not actually going to be able to get the brace to the level that we want, but it's worse than that still. When we're using the lumbar support brace, often it's the individuals that struggle so terribly with actually being able to even provide any of their own intrinsic stability to the spine that end up leaning on these sorts of things because they're struggling, right? And rather than learning the appropriate things, they lean on these braces and continue to bend and shift all over the place in spite of wearing the brace. And why is that even worse? Because when we are struggling with a lower back issue, we don't have cognitive control over the individual segments of the lumbar spine. All we have is the ability to bend it one way or bend it the other or twist it, etc. And the movement will flow through wherever it's going to flow through. So when we have a healthy spine, the movement will flow through each of these segments in an appropriate manner. When we have, however, an injured spine, we have injury to the structures that provide stability and integrity and tension, resting tension to these segments. So we're talking about L4-5 and L5-S1 down here. So now when this person moves and bends, often movement preferentially goes through the point of weakness, which is why when you moved, it hurt because L4-5, that one you've got the disc bulge on, got strained a little bit. And so, ouch, it hurt because it moved, not because it stayed still, because it moved and it strained the tissues. And so as you went to reach something, it hurt. Now you imagine you've got a brace on. Number one, the brace gives you this false sense of security. And number two, let's assume the brace does work. And I'm not really sold on whether the braces work or not, because there's so much stuff here. You wouldn't dream of putting the knee brace on and then packing it out with bubble wrap about that thick. And so I'm skeptical as to the utility of the brace here anyway. And if you're a powerlifter, if you're a bodybuilder, you don't have back pain, go somewhere else, right? Because this isn't making the case for the use of the back brace in the athletic environment. This is making the case for the back brace with the injured individual. So let's just assume that it is effective at the level it's put, which means it's bracing this area, which means less movement is going to go through here, which means even more movement will end up going through those injured segments in the individual that's not got appropriate levels of spinal control, which is why they're leaning on the belt in the first instance. But it's actually a double negative because the belt stops upper levels of the lumbar spine from working so that that movement that was going through the lumbar spine now preferentially goes through those injured structures. So long story short, leave belts alone. Learn how to control and stabilize your own spine with your own built-in support network, and you will do so much better, so much better. And if you're using a belt because you think, oh, well, it provides me some relief or it feels good, so you can do more bad stuff, we've got it on our head. We're using it in the same way that people use painkillers. I always remember a case where a lady was getting stronger and stronger painkillers until she was anxiously waiting, looking forward to the prescription of her morphine so she could carry on going back to the shops and stacking shelves while simultaneously being anxious about doing exercises. I was like, are you kidding me? Are you kidding me? It makes no sense. It's on its head, and no wonder we're not getting better. So hopefully that bit, I'll go into some questions now on TikTok. Guys, those of you on YouTube, you can always post in the comments as well, and hopefully this is going to help some of you guys. B3GR8 said, bulging disc, I feel pain all over my back. It's not unreasonable to have a good or a diffuse degree of muscle spasm in that area of the lumbar spine. Christine has said, last March I was suffering spine due to muscle spasm. Not sure what that means. But if we have so traumatic I can't sit and stand, you just got to start with the rehab work. Random Act says, I had flare-ups while doing back extensions, then did sprints, and I could do them fine. Why? Most often, one of the things that we recommend people when they go back into running is actually running faster. And when you're running faster, you will feel this, right? Everything's tighter through here. It's more neutral, generally speaking. You're running, but you're relatively neutral in the lumbar spine. You're not going back into extension, you're not going forward into flexion. And you've got a lot of support and engagement. And so it might well be that you're gaming the system. We're not vulnerable enough for the sprinting to be problematic in the moment, and we have a good degree of control and form as we're running, so we're providing that extra extreme level of stability to the lumbar spine whilst without any significant end of range motions while we're doing the running. Jeff has said, can you explain how squats help the back? Because when I squat, I feel my quads and glutes fire up. Awesome, that's perfectly reasonable, Jeff. How do the squats help you? The squats help you specifically in a number of ways, and I hope this really makes sense to you guys because it's explaining the mechanism of action for your lower back. We could also make the statement that the back in shape program is really a hip in shape program as well, because quite frankly, it works the legs. We're leveraging the legs. So the first benefit of the squats is that, in fact, no, let's take a step back further. Your body is trying to heal every single day. You have a herniated disc, bulging disc, an injury to the lower lumbar spine. And so that is trying to heal every single day. But there are things that those of you that are struggling to get better, there are reasons why you're not getting better. And that is because you are proverbially picking the scab every day. You're doing little things every day that are aggravating those tissues. And those tissues heal really slowly. So when you pick a scab on the surface of the skin, it heals pretty quickly and it'll react to that picking of the scab. These tissues way slower. So each time you aggravate it and irritate it unnecessarily so during your daily life, you're just kind of getting step changes of things getting worse and worse and worse. And so the squat in the first instance, when you're learning the technique, you're learning how to do the movement in a way that does not compromise the lumbar spine, that exhibits control, etc. That immediately should be, and this is where education is important, applied to movements of daily life. So the squat itself doesn't directly help the lower back in this instance, but it means that you are helping the back by stopping messing it up. So that you're learning how to actually get out of a chair correctly without kind of doing this kind of silliness. You learn how to control yourself on the way down. All of these kind of, so the little aggravations start to stop happening. You're also building, when you perform a squat correctly, you are building the midsection stability, right? If you don't engage your core, you just flop forwards and then you do a squat. And people do that when they first start the squats, right? They do silly things like that and they don't even know they're doing it because they don't know what's right and wrong. So when you're doing a correct form squat, you have a strong midsection and posterior chain that holds stability whilst the legs do stuff. Hence why you feel it in the glutes and the quads. Maybe the hamstrings, maybe the calves a bit as well. And so you're teaching isometric strength. And then steadily, you're going to apply load to that same movement, challenging the muscles that provide isometric strength and work synergistically with the movement down here to create coordination balance. And that further has an additional positive impact on your recovery because it means you're safer and safer and more resilient because you've improved your strength and competence at this movement. So when you have to do more complicated things, you've just got a greater level of base support, stability, protection, so that healing can continue to take place. And then later on, because again, it's working this midsection, as you start to load up and challenge those muscles a little bit more and the load a little bit more, this is more medium to late stage of recovery, the squat is literally putting load through these sections of the spine here, the sections you've injured. And so that is building the very load tolerance of the discs that have been herniated, damaged, etc. The load-bearing structures that you guys have injured, they are getting stronger through the squat Why the squat? The squat and the hip hinge? Because they're the safest way for you to reliably, with good form, apply steadily, incrementally increasing amounts of load to this spine to create the stimulation so that it knows how strong it needs to get. So in the short to medium term, the squats are not directly helping with the remodeling and strengthening process in the spine. They are helping by protecting it from aggravation. And because the squat and the hip hinge and the step up, for example, are so emblematic of many, many movements that you're doing every single day, many, many movements that could be done in a way that stops aggravating your lower back. And so there's a significant benefit. Some people, just for learning how to do these movements correctly, notice very, very, very quick improvement in their day-to-day aggravations, even if they've had it for a very long period of time, because they've never been given any instruction on these things before. Like even to the point where we're with people in the clinic and the guy goes, every time I get up, my back hurts. I'm like, show me how you get up. I'm like, well, why are you doing it like that? He said, I don't know. That's how I get up. I was like, well, don't do it like that. Do it like this. Engage yourself. Get your feet underneath your heels or your feet underneath your bum. Brace yourself a bit more. Engage and then come up. He said, oh, wow, you fixed my back pain getting out of the chair. I'm like, no, I didn't. I just stopped you aggravating it so that the poor thing can actually start healing again. That's all we've done. But if you start building on that, there are so many examples, getting out of the car to come into the clinic, getting back in the car to go out of the clinic. You start to become more aware. That's how it helps. And then obviously later on, it's literally building the strength and resilience of the things that you've injured themselves. What other comments have we got here? Does stretching help with the bulging disc? So we've got two different types of stretching. Number one, we've got stretching of the hip musculature. So that could be a hamstring stretch, your glute stretch, etc. But all too often they're done incorrectly. And so these have second order benefits. It's very important that we understand what is doing, which is why Jeff's question is a great one. I had this one as well. When we do a glute stretch and we bend over like this, look what I'm doing to my lower back. How we do it matters. The glute doesn't do lumbar flexion or extension. The glute does hip movements, right? And so when we're stretching the glute, we don't need to involve the lumbar spine. In fact, you'll find that if you straighten up the lumbar spine, you'll actually feel that it's a better stretch. The same goes for the hamstring stretch. So people do these in a way that's aggravating the lumbar spine without even knowing. Hamstring stretch, rounding the lower back. Again, problematic. If you do them correctly, they have a role, a temporary role. People think that these come firmly in the relief category. Relief category are things you can do each day that have no cumulative benefit, but they're worthwhile doing because they take stress and strain off the lumbar spine so that it can go through a healing process. Your hamstring stretches will temporarily mobilize the hip joint, which means the hip joint can move a bit better so the movement doesn't translate as readily into the lumbar spine. However, you have an L4-5 and L5-S1 disc injury, meaning there's very likely going to be some descending signals to result in dysfunction of the hamstring. So they're probably going to tighten back up again pretty soon. But it's still worthwhile doing because it takes about 30 seconds to a minute to do each leg, and you might get some residual benefit over the next number of minutes to hours. So hey, do it anyway. You can do it while you're just literally sat there watching this video. But do be under no illusion that the hamstring stretch is doing anything more than providing temporary relief. And that's a very, very important thing to understand. Now, when we've got things like decompression stretching, we've got things like the bed decompression. These are directly taking pressure off the disc gently. And so those are great options as well. But again, they're helpful for creating more space in the disc, helping getting that exchange of nutrition in and out of the disc, but they are not long-term strategies. So they are paired. For those of you guys that come through the program, we've got the core relief work, which would have some hamstring stretching, some other stretches, some decompression stretches, some contrast bathing, etc., which is temporary. And then we have our rehabilitation work, core 1, 2, 3, 4 phases. And that is actually what is building strength and resilience, getting you better, so to speak. Driving is the worst, sitting down is painful. Yes, the reason sitting down, Craig, is painful is because when you sit down, you put 40 to 90% more load through the lumbar spine. A very helpful figure for all of you guys that are struggling with back pain to get is what do you want to do on a squat or hip hinge? You guys can't see, but I'll turn you guys around so you can see. Oh, maybe it's, well, there we go. There's an 80-pound kettlebell over there. You guys on YouTube, you can see that kettlebell, right? Can you do that right now with your bad back? The answer probably is no, right? For some of you guys, it might be yes. Let me just move this around a bit. Now, have a think about what the current 40% figure is. So if we calculate what we're putting our load through our spine when we're standing, okay, so I'm 92 kilos, 92, 93 kilos. So around about 50 kilos of upper body weight is squashing down on my spine, roughly speaking, right? You just want a rough idea. So 40% of the 50 kilos is going to be added when I sit down. So that's going to be 20 kilos of extra loading through my spine. Depending on how badly I sit, that's going to increase the strain on the lower lumbar spine. So if I'm only squatting body weight and I haven't made it any further. Is it any wonder that sitting hurts? Is it any wonder that driving hurts when I'm sat in the car like this for hours on end? Well, of course it's going to hurt. It's going to be problematic. Now, there are a certain group of population where there's a certain quirks around their back injury, their sciatica perhaps, that mean that sitting like that feels relieving, but they get terrible pain when they go to stand up, and there's reasons for that, and I can explain those if the questions come up. Kerem has said, I've been following your program, it's really helped me. Awesome. Recently I felt a bit of pain when doing squats at 5 kilos. Do I have to start over with the exercises of body weight or keep going? Kerem, I would definitely get into the members group if you're in the program and get some videos up, get some commentary in. Specifically, when do we get the pain? Specifically at what part of the exercise? Specifically at what rep number, for example? This is all important, right? Is it happening every time or is it happening sometimes? And there are other strategies we can take, right? For a lot of people, when they're starting out with things like the squats and the hip hinges, they're not very good at them, which means that you maybe do the work, as Kerem has probably done here, to find the right depth, right? I know that if I go down to here, I'm okay, but when I go lower, I start to round my lower back. You guys can see, right? So what I do is I get a chair, and this chair is the bottom point. That's good, okay? So every time I'm doing my squats, especially when I'm starting with a new weight, I always squat to the same depth, right? To make sure that it's standardized. Because the problem is for you guys, when you're beginners, when you're starting this out, that's your appropriate depth. Sometimes you go to it, sometimes you come short, but sometimes you accidentally go too low. And that's a problem. And so using the chair helps you standardize the depth of reps so that you decrease the risk, especially as you start adding in the load. There could also be factors, and these are just, I'm putting ideas out there for Kerem, and he can reflect on these and post in the members group, I would suggest. But it could also be a factor that you've just stepped up to that level. And maybe we've got a bit of DOMS, delayed onset muscle soreness, tension, tightness in the musculature. And that tightness restricts the hips and starts to irritate the lumbar spine. So we're not managing. One of the things that we must be vigilant of, and we've got educational units on this in the program, talks about the presence of DOMS. As different people get to different stages of the program, they start to get some stiffness, some restriction developing as a normal part of the recovery process, of the strengthening process. And not managed effectively, those can start to irritate the lower back a little bit. So it's something to be vigilant for. Hopefully that helps. Georgina said, I've had radiculopathy and sciatica for 1.5 years. The progress is very slow. Every few months I re-injure myself, doing almost nothing, and start all over again. I work standing for 1 to 2 hours before I'm having to lay down. Georgina, you need to do the rehab work. The question is, in those instances, what are we doing for rehab, right? Progress is almost certainly going to be discussing the progress in your symptoms rather than progress in your rehab. And where we focus on progress of symptoms, we are missing the point because we don't really have any direct control over that. We do have control over the progression of our rehab. So I've gone from body weight to 5 kilos to 7 kilos to 10 kilos. I struggled at 10. Okay, well then we have strategies to help in that process. That's where support comes in, right? Because everybody's going to have challenges at different places. And some people will have challenges in the early stages. Some people have challenges later on. And having that support along the process really can make the world of difference to navigating through these things. But one thing that tells me for certain is when we injure ourselves doing almost nothing, we're not actually doing anything to rebuild the spine stability or not actually making enough progress there, which is why we're vulnerable. So all that happens is we have a significant flare-up, we irritate the tissues, maybe in a minor way, through something insignificant, as Georgina said. And that creates an inflammatory reaction, which creates a lot of symptoms. So our symptoms spike. Now we're really, really struggling. And then as we go, as the inflammation starts to calm down, because we're going on how we feel, we think, oh, I'm feeling better again. So we think we're feeling better. We haven't done anything to get better. All that's happened is inflammation has calmed down and healing's trying to take place. But we haven't driven the strengthening process. So we're no different. And then we're vulnerable. And then the next little thing happens while we're putting our socks on in the morning. Georgina, I don't know what the rehab program is from the PT specifically. And that really does matter, but evidently we're not necessarily having so much success with it. And I think one of the important things to note, which is often misconceived, is that the program, people think, oh, well, I need a specific program for me. It's like, no, you don't. You need a specific program for the back that is principled and that makes sense. And it's not just about the exercises, it's also about the education. So we have people with every single conceivable diagnosis that you can have. You've got people that have had surgery, that haven't had surgery, that have had disectomies, that have had 2 disectomies, that have had injections, that have had bolts put in their spine, artificial discs, and everything in between, all the way up to the minor strain of the lower back. And they're all doing the same program. That's very important because the program is built on how to rebuild health in the lumbar spine. As far as I know, you guys have issues with the lumbar spine. So the program is for that. Now, you wouldn't join a shoulder program, so you do need a program for your area of interest, let's say. But our target is to rebuild strength and stability and health in that lower back. And so the difference, the uniqueness, and this is where people really need to understand where the uniqueness comes in, where the tailoring comes in how you go through the process. So Georgina, with her diagnosis, will have certain challenges. Maybe she starts straight out and she can't engage the core very well, so she has to get more help and tips in building that. Other people, maybe Karam, he's struggling to get past 5 kilos on the same program, but he struggles with that part of the program. And that's why support is so important. That's why troubleshooting is so important. That's why understanding the concept is so important. Whereas someone else still might really struggle with going from 25 to 40 kilos. They can get back up to that level, but they always hit that barrier. And there are reasons for that, because maybe they're getting blindsided by the DOMs that they experience and they're not managing that very well. So very, very important. B3 has said, do you think stress plays a crucial part in the recovery process? I think stress makes everything worse. Think about the last time you were stressed, or you know someone that's stressed. Did they adopt this position? I mean, they may have felt like giving up and being like that. Or do they go like this? Oh gosh, look at my lower back. The postures that one adopts are removing the cortisol and all that other kind of stuff. Let's just make it simple. The problem is everybody's trying to make things too complicated. Let's make it simple. The posture that a stressed individual adopts regularly is not one that's going to be optimal for a lumbar spine or recovering from a lower back injury. They're going to be rounded. They're not going to be doing much. They're going to be like all the time. If we're struggling up here, we're not going to be standing up tall. And those things make a massive difference. I always remember a study, and I can't remember the exact details, so I'm going to butcher this a little bit. It's a long time ago. And they took guys and they were looking at testosterone levels. And there might have been cortisol in there as well. And they got the guys to literally sit in a posture. Some would sit in a very open posture, very kind of masculine type posture. Others would sit like this for an extended period of time. And they did blood draws looking at their levels of hormone, testosterone, and I think there was cortisol in there as well. And just the postures that that the individuals were adopting between groups was enough to change some of these levels compared to the baseline when they walked in. Very, very interesting. Very interesting. The mind does significantly, and the posture and all these things significantly affect us. But like, if you're not doing the rehab, forget about the posture, forget about the other stuff. Like, you have to do the doing, right? We have to do the doing. And the irony is, in doing the doing, you feel like you have more control because you've got a structure that you can follow and do, and things that you can actually take agency over, and that helps you up here. So it's just like, just get started. And once you get started, you'll feel like you've got a bit of that control back. Because too many people are going around with their back pain going, can you fix me? Can you fix me? Can you fix me? Rather than going, can you help me fix me? Let's go and do it together. That's how it should be. That's the reality of it, because you have to live with you 168 hours every single week. And no matter what anyone does, they can only have so much impact on that, unless you're willing to have them live with you. And that's probably not something that either of you guys want. Storyteller said, after sciatica, my back is super sensitive. I'm resting for 60 days and a little bit of movement and exercise irritated sciatica. Can't even bend without extreme pain. This is an example of what not to do, I'm afraid. Sorry, storyteller. Like, quote unquote resting, I don't know exactly what resting is, but what's most likely happened, this is why bed rest is so ill-advised, is that what little muscle mass we may or may not have had in the past has significantly been lost. So anytime you move, you've just got no control over the body. And that makes it a difficult hole to climb out of. You can do it, but you've got to realize that you're starting from a very low bar. And so getting started with simplistic exercises that build stability back in, realizing that it takes time to rebuild muscle tissue that has been lost, not days, and you're certainly not going to get it right first time. That's the only way to rebuild strength and stability. And sure, you're going to have significant pain. Bending is going to increase the forces on the spine. So saying I can't bend without extreme pain is like, well, yeah, of course. You need to focus on stability and rebuilding some element of stability so those tissues can re-strengthen, right? As an example, the strengthening process is a healing process. I currently cannot deadlift 230 kilos because my tissues are not adapted to doing so, but they were in the past. And because I stopped doing it, they down-regulated. When we have a period of rest and significant inactivity, your body will literally break down because it says, we don't need to maintain this level of resilience in the body. And if you're not delivering anything to provide the stimulus to maintain that health in the tissues, you're going to struggle to make any meaningful long-term building of resilience. You're just going to break down. You see this as examples of the rehabilitation that astronauts that go and live on the space station have to do when they get back. Those guys that were left up there for a long period of time, I think it was last year, like you have to do significant, because the body requires stimulation. The cells need to be told what they need to do, how strong the body needs to be, and it's very expensive to maintain structural integrity in the body. So you have to drive that process, and that's why bed rest is such a terrible idea. It's really difficult. And the reason I think we go to bed rest is because we give up. You know, we're like, oh man, I don't know what else to do. I just won't do anything. And then maybe I won't hurt. And then that gets us stuck in a very, very difficult hole that's hard to climb out of. What were you doing? I was working for 10 hours a day and doing rehab work after work. Do you think I was overworking my back? I'm 22. I think it depends on what we're doing in the office, you know, or in the building site or wherever that is. Some of you guys are going to have to figure out when you feel like the most impactful time of day is to do your rehab work. Some of you guys won't be able to do it after a 10-hour day. Others of you will actually feel that that's fine, right? You have a little break and then you go at it before you go to bed last thing. Like there is some, we typically say, ideally, you do relief-based work in the morning and in the evening, and then you do your strengthening work in the middle of the day. That's not necessarily possible for everyone. I don't know if you can get a lunch break and go and get an hour and you go and do your rehab work then you carry on, but you're going to have to manage the stiffness post or the consequences of the workout post while you're in the office in the afternoon for that 5-6 hour stint. So we've got to have a bit of strategy, and that's why everybody needs support along the process. Support really can make the difference. A lot of you guys will be able to do it on your own, but support can make a big difference in these kind of quirky setups to give a bit more strategy and guidance. The questions that we've got in here. Sleep positions, even side sleeping hurts. One of the big reasons that side sleeping hurts, especially, I don't know if it's a lady or a guy, but particularly for ladies, the same is true for guys, it's just not quite as pronounced, is that for ladies, you have very wide hips compared to the waist. And so what often happens is the pelvis rocks one side or another. And you'll find that because the spine is not straight, it's tilted, that creates more aggravation. So if you can try and set yourself up with a neutral position, sometimes popping a little pillow underneath here or a small towel to stabilize the spine can really help. A pillow between the knees can really help. Adjusting the position of the legs. Like for example, I'll try and demonstrate this, see if you guys can see. If you are in this position here, if you're sleeping like so and you drop one leg off, you can see with my shirt line, it tilts my pelvis that way. And then if I bring it back up, it straightens back up. And then as I drop the leg, it tilts. Now different degrees of dropping will tilt the pelvis to a certain degree. Playing around with that can game the system a little bit and create a little bit more comfort. But ultimately you want to try and have a neutral spine when we're lying down for long periods of time. That's the ideal. That's the kind of premise or principle behind some of these funny positions that you see online about like instantly fixing your sciatica in 3.5 minutes, is it's playing around with the mechanics and the specific nuance of your specific direction of disc bulge. It's not doing anything to provide long-term relief, but it is gaming the system to try and create a position of comfort. Hopefully that makes a bit of sense. What other questions have we got? Can I start to work again? I've still got a bit of a disc bulge. I've become more strong. The question is how strong? The great thing about your rehabilitation work, your strengthening work, is that you have an appreciation for exactly how strong you are. If you're only using a 5 kilo weight, but your day job is going to involve picking up things that weigh more than that, we need to have some strategy. We need to have some conversations perhaps about the suitability of those kind of tasks. But if you've built yourself up, the idea is that your rehab flows into strength training. And then it's a case of how much strength do I need to do the things that I want to do. The idea is that your gym work, your rehab work, your strengthening work is so much up here, this is long term by the way, that the chances of a daily life stress and strain getting anywhere close to your capacity is very, very slim. The problem is your daily life strain for so many of you compared to your actual capacity is the other way round. And just like the example from Storyteller doing the bed rest for 60 days, that's a real problem. Because the act of going to the toilet from the bedroom is more strain than your lower back is conditioned to deal with. And that's a difficult one to turn around. You can turn it around, but you just need to that's where knowledge comes in a big way. The academics is so important because the understanding can help you go through the difficult times a little bit better if you understand it. Louisa said, I had a discectomy last year and re-herniated. I have a lot of pain sitting. It was L4-5 and a disc herniation at 5S1. The facet joint was removed, or 50% of it. Not sure what is mainly causing pain anymore. I'm currently pregnant, which isn't helping. The pregnancy is going to be something that's difficult to navigate. I'll park that for 1 second and just deal with the disc herniations. It's very clear that we haven't had the appropriate rehabilitation work. We've got to have success with the rehabilitation work and rebuild strength and resilience. When we have a discectomy, we are with a good surgeon, they're going to communicate this to you. With the maybe more pressed for time surgeon, they're probably not. The problem with the disc bulge is that the disc material in here, the nucleus, is constrained and held in place by an intact annulus fibrosus, which is like the skin on a water balloon. The water balloon skin is what's doing the load bearing, not the fluid, fundamentally anyway. And so when we have the herniation, the problem is not that the herniation has taken place. The problem is that the tissue damage to the annulus fibrosus has allowed the herniation to take place. When you have a microdiscectomy, you're just chopping that off. You are doing nothing to deal with this. So post microdiscectomy, you're still just as vulnerable as you were beforehand, I would argue. Now, you might have had some almost miraculous symptom improvement. That can often happen. But nothing has been done to rebuild strength and resilience into that disc. You are no better off the day after the surgery than you are before in that regard. Symptoms otherwise, right? That's separate. But understanding the problem, the root cause problem, which is the damage to the annulus fibrosus that has resulted in the nucleus moving to a position where it's caused you trouble in different regards, is the problem. And so if we haven't been doing anything to deal with that, the same factors that caused the herniation at L4-5 are still present. The same misuse of the lumbar spine is still present. The same forces that are not being contained, that are not being supported and protected from, is still present. So it's perfectly reasonable that we're going to either re-injure the segment that's been operated on, as frequently happens, judging by the comments, or that we injure another segment. L4-5 go together, hand in hand with L5-S1. Those segments are so closely related to one another in terms of the dysfunction. And so that's why you're getting the pain, because we haven't done the rehabilitation work. Now add on to that a layer of complexity with the pregnancy. That's going to be tough, but you just have to do the best you can. You just have to do the best you can. And as you go through the pregnancy stages, you're going to have to modify certain things. You're going to have to focus a little more on trying to do symptomatic relief without making the problem worse. And then post the other side, once the baby's here, it's very, very exciting. You do what you can as a new mum. And then when you get to a point where you can start to focus on yourself a little bit more again, which is questionable when that point comes, but you try and get yourself doing better again. And you will be able to. You will be able to. It's just going to take a little bit of time. And then obviously there's considerations of things like C-sections if we've had those, and rehabilitating the control of the core. But you can start that right now, and you'll at least be setting yourself up for the best possible circumstances. Storyteller said, I had steroid injections, but after hip hinges, I got a flare-up. My physio said even slight extension or neutral position puts pressure on the disc and makes it worse. I think they may be a little bit wrong there. Slight extension does not put pressure on the disc. Slight extension takes pressure off the disc. Neutral position puts the most optimal pressure through the disc, and flexion puts the most pressure through the disc. And with hip hinges, when we're learning any exercise, hip hinges is one of the ones that people struggle with often. And it's how we're learning those. For example, a simple little thing that makes a difference, right? When people do hip hinges like this, that is not a good way to do a hip hinge. Like that, much better. You can catch yourself on your knees. Better yet, if you're really vulnerable, you can do it in front of a chair so you can catch yourself on the chair. All of these kind of things can make a difference. How we do it makes a big difference. The physio, I think, maybe doesn't understand things quite as well as they should do. But sitting puts more pressure on the disc than standing, and the extension actually takes pressure off the disc. It puts more pressure on the facet joints. Generally speaking, in the neutral position, which is a lordotic position of the lumbar spine, you've got around about 70% of the load goes through the disc, and about 15% goes through either one of these facet joints. As you move further this way, it increases the loading on the disc. As you move further this way, it increases the loading on the facet joints. Nice and simple. Bending forwards, disc, bending backwards, facet joints. Now, if we've got disc herniations, there are other bits and pieces there as well, but that's maybe for another question. Storyteller says, I have to go to uni and can't even sit in resting position for a minute. It's tough. It's tough. You've got to do the rehab. We've got to do the rehab. Ree says, I think my body has gotten stuck in a scared position. Scared to do a lot, of being very stiff, worried about even worried to bend even slightly in case it makes things worse. Focus on stability. Focus on rebuilding stability. As you rebuild stability and you use the sort of stuff that we talk about, you'll start to build confidence. Yes, you don't want to be bending. You do not want to be bending. You've got a vulnerable disc. If you're worried about loading in a neutral position, you have a right to be worried about bending, because you're going to be putting significantly more strain on those tissues. So the thing about doing the load bearing as a mechanism for building load tolerance in a neutral position is that this is balanced. If we're loading in a flex position for bending, we are squashing down on the front, driving the nucleus back. So we are loading the posterior parts of the disc more. We're putting them under more strain. So there's no need to worry about bending forward. You should be trying, this is what we talk all the time to members about, you should be trying to focus on a neutral spine and then build from there. And that's why education comes in really important as well. You have to understand the exercises that you're doing and the premise and the approach and the philosophy, otherwise you'll end up tying yourselves in knots. That's why we put so much effort into education. What else have we got here? Comments, questions. So you don't recommend support belts? No, we do definitely not recommend support belts, primarily for the function and reason that they do not go at the segment that is problematic. And unless you are a skeleton like this, you cannot get them to actually be at the level of L5S1 or L45. And I'd even question how good they are in the first instance. Use your own support belt. You've built one, use it, learn to use it, and you will do significantly better. Shaz says, why do you think there's such a variance in advice for this injury? No other injury is like this. Because people, with every other injury, they're focused on the actual injury. With back pain, they're focused on the symptoms. That is exactly why. And there are nuances with the back that we don't have in other areas. One of the issues is the inflammatory issue. So with other injuries like the knee, the ankle, we don't really worry so much about the inflammation because we know it's a good part of the process, right? And my knee was swelling up and I had a little, on this side, and I had a little golf ball sized bit of inflammation in my knee after I'd had my meniscus tears. And it's like, oh, when I do that, it sticks out. That's something, you know, not the worst meniscus tear, but they weren't so great, and they were on both of the medial and lateral. But I don't have to deal with the consequences of that. Whereas in the lower back, the inflammation building up around here means that you feel like you need to forward bend. Back pain, it's all about back pain. Everyone's talking about my pain, my pain, my pain. So people are operating for the philosophy of dealing with the pain relief at the expense of the problem. That's why there's so much variation in the lower back, and cervical spine, I would add, in lower back advice. Many people are talking about relieving pain. And if the primary problem, according to the individual, is the back pain, the back stiffness, the sciatic pain, then you will do things to ease pressure on those things. So you will stretch the muscles and you will try and open out the spaces. And that's why those things are so frequently recommended, because people are focused on the pain, those practitioners. But if they knew about the problem, and that the problem is the actual injury, then they would set about creating a structure and a framework to rebuild the strength and stability of the injury. The back is also very different. You can't control the individual segments that you injure like you can control a knee. So I can very reasonably do certain things to start to get control over my knee joint to rebuild strength and support around the area. You can't do that with the lumbar spine because you can't control L5S1 discretely from L45. So they're not aware of these, or they just don't know, or they don't choose to know, or they don't choose to go in that. And you have to appreciate most people are generalists. Most practitioners, physios, etc. are generalists. They're seeing lots of different people. They're working in a generalist practice. 1 week it's a shoulder, 1 week it's this, 1 week it's that. They just don't have the experience working intrinsically with the entire back injury, seeing the spine, for example, understanding that they haven't built up that knowledge base to focus on the spinal problem rather than the actual symptoms. Even the surgeon, which really I would argue should know better, but their job is to do surgery. That is their job. I always remember listening to a really good surgeon talking about the knee, said, my job is to put this piece of metal in your knee. Your job is to work and do the rehab so that you don't mess it up. His job is to put the thing in the knee. His job is not to deal with other aspects of it. His job is to just put that in the knee. Very interesting take on it anyway. Generally speaking, when will I be able to sit for an hour in flexion? Why do you need to sit for an hour in flexion? Sit correctly. Sit correctly, storyteller. It's like, when will I be able to drink 10 pints with the guys in the after work in the office? I don't think that's something that you need to be worrying about, quite honestly. Focus instead on building strength and resilience into the lumbar spine. And it's very difficult to answer that question. When will you be able to load tolerate? Load tolerate what? When will my disc be healed? Healed for what? This is the quality of the answer will be dictated by the quality of the question. And so when will I be healed to carry my toddler? They weigh 15 kilos. So am I doing 15 kilos on my squat or hip hinge? No. Okay, well, I'm probably going to be a little way off that then. Maybe that's not such a good idea. That's why I mentioned earlier on in the live session, which some of you guys might not have been here for, the 40 and 90%. Figure out, storyteller and others that are struggling with sitting, what is 40% of half your body weight and what is 90% of half your body weight? Those have numbers. For me, it's 20 kilos and 45 kilos. So if your squats and hip hinges in the neutral, best possible controlled position, if you're not able to do those loads, then you've got some work to do. It would be reasonable to suggest that once you can get close to those kind of loads, you will notice that things like sitting become easier. So the question then is not nebulous. The question is, when will I be able to squat or hip hinge for 45 kilos to break that threshold of the 90%? I don't know. Neither do you. Just start working towards it and you'll get there. Might take you a couple months, might take you a little bit longer. It varies from one individual to another, but one thing you need to do before you start messing around with weights is figure out how long it's going to take you to learn to even perform the exercise correctly, and then go from there. And that might sound like a lot of work, but do we want to fix, or do we want to just mess around? So hopefully that helps. I really hope that helps. Can pelvic tilt position when walking affect things too? Does facet joint that was removed affect certain rehab I should do? You still need to work on stability. I would not be doing pelvic tilting of any sort, and I would not be worrying about any sort of pelvic tilts. Too many people get tied up in, is my pelvis tilting one way or another? So firstly, it's almost never actually measured. To what degree? We've got a 23.5% increase in the anterior pelvic tilt from the neutral. We've got a 37.4% posterior pelvic tilt relative to neutral. You need to have those kind of numbers, and they can only really be gleaned from a standing x-ray. And so, and then the question is, what makes you think you have the capacity to be that specific in your correction of that pelvic tilt? And how do you know you're not just making it wrong the other way? So don't worry about that. These are unnecessary layers of complexity. We should assume that we have a normal neutral spine in the upright position unless we have evidence to suggest to the contrary, and we have numbers as to how far away from neutral that is. And then we can actually make sensible strategic decisions. Yvonne has said, what can I do for foraminal stenosis? Start by understanding what's causing the stenosis. Stenosis is not a diagnosis. Stenosis is just saying that hole is smaller. That's not helpful, right? Invariably, it's going to be something like a disc bulge or herniation is in the space. It could be that we've got a spondylolisthesis, which means that the top of the hole and the bottom of the hole are now like that, and therefore the hole has changed shape, and there's obviously going to be a bit of disc bulge in there. It could be that there's something called facet joint hypertrophy, which is going to go alongside those recurrent disc injuries, and therefore we're going to have an enlargement of these facet joints, and if they grow and they grow this way, then they're going to make the hole smaller. There's a number of different reasons for the stenosis, but the stenosis is never the problem. The stenosis is just a description to say you've got something happening here and there's a smaller hole. But if you have stenosis, then you're going to find that inflammation from a relatively minor strain flares up a little bit faster. And for those of you with stenosis, so Yvonne has L3, 4, 5 and S1 bulging, so those would be the causes, right? You can see very clearly this spine is stenosed, right? Try and get on the camera, there we go. This spine is stenosed, why? Because that hole on this side has a bit of disc in the way and this one doesn't. So this has got spinal stenosis at the segment. And you can see how that's useless information fundamentally. I mean, it's not telling me anything. The L3, 4, 5 disc bulge is there. That's what's telling you what's wrong. We've got a disc injury at multiple levels, which indicates probably a good degree of poor movement habits, rounding of the lower back over an extended period of time, maybe a desk-based job, that kind of stuff. These are all the kind of things that preferentially strain the lower section of the lumbar spine, and probably why we have such a common instance. 90 to 95% of you guys with back injuries and sciatica will have injuries at the L4, 5 and L5, S1 level. You know, that's why, because of how we use our body every day. What would be the reason that I started having pain when sitting properly versus sitting relaxed? So there can be a couple of reasons for this. Number one, if we've got a particularly profuse disc bulge and we have a good degree of inflammation in the lower back, as a lot of you guys are stuck in a flex position because you make these holes larger, because you just feel like you can't get back to neutral, which is very, very common, by the way. So when you do try and actually sit more neutrally, the inflammation in this space gets squashed and it irritates the nerves a little bit. And that's why managing this with things like contrast bathing, icing, etc., can really help manage the inflammation and make it easier to get into a position that's putting less strain on the lumbar spine. It could also be that you're not actually used to using the musculature that holds you in a good position. If you sit in your office and you look to the left, there are 5 people to the left of you and 5 people to the right, they're all sat in different positions and many of them will be perfectly comfortable in that position. And if you asked each individual to copy the posture of the person to your right, they would all of a sudden all be uncomfortable. So we do condition ourselves to certain postures. Mill says, do you have any advice for someone with Bertolotti syndrome? Yes, act as if you don't have it. And I know that sounds really tongue-in-cheek, but Bertolotti syndrome is a version of sacralization of the lumbar spine. It is a congenital defect. It means that where the L5 should be its own vertebra, sometimes the transverse process here has what's called a pseudoarthrosis, a fake joint with the sacrum. Sometimes it's fused, sometimes it's one side, sometimes it's both. Sometimes it's fused on the front as well. It really varies. But the most important thing to understand is you've had that your whole life. And while you may have had back issues for a long period of that life, you will have had a period where you have not had back pain. And I think too often poor dealing with the person's lower back pain results in them looking for answers, and then someone goes, oh, you've got Bertolotti's syndrome, that's the problem. It's like, no, 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 no. You've just dealt with the back injury badly over an extended period of time, and now we're clutching at straws saying that's the reason why we haven't got better. No. The reason we haven't got better is because we haven't done the right sort of rehabilitation work, and Bertolotti's syndrome is no different to anything else. It does mean that you've got a bit of inherent disadvantage compared to the average person. The same as the person that's had a spinal fusion at L4-5. You guys have certain anatomical variations, which mean that it's more important that you adhere to principles that we talk about, right, compared to others. It's still important for everybody else, but even more so for you, because you need to have control over the lumbar spine because you have one less joint. And maybe it's a bit quirky, as I mentioned earlier, there are different variations of Bertolotti syndrome, one side more than the other. Maybe it's a pseudoarthritis, maybe it's just completely fused. It varies quite significantly. It's an anatomical or congenital defect fundamentally, but you've had it your whole life. And so spine stability first. Once we've built good spine loading, the sorts of targets we talk about are for ladies, 75% of your body weight on a bar or any other load, right? And men, 100% of the body weight doing a squat or hip hinge for 10 reps without any aggravation, without any deviation of form. That's a target. Then, long term, we want to have better than average hip mobility. Why? Because we've got an abnormality in the lower lumbar spine, we're always going to have this feature. And so if we've got good stability here and slightly better mobility of the hips, we are going to offset the fact that there's one less functional joint in the lower lumbar spine compared to the average. If the pain has been constant for years, do you recommend surgery for the Bertolotti? I think I'd be very, 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 very careful about doing that. Years is not the same as your entire life. There are many people without Bertolotti syndrome that maybe even be in this chat that have had back pain for years, that have had sciatica for years, that have had herniated discs for years. I'd be very, very reluctant to start going and chopping bits of the body out, especially if we probably haven't been doing the sorts of stuff that we talk about with success up until this point. I'd really give it a good chance, because you can always have the surgery later, but you can't give a good crack at the rehab work. And I think you'll find that it turns things around when you start doing the right sort of stuff. Curlo said I work as a cleaner. Kerala, sorry. I said I work as a cleaner. I have to change lots of bins, which involves bending. How could I bend? One of the best things you're going to have to do, you know, one knee, boom, do it down here. Have some support around you. Come back up. Like those kind of strategies. You might, I know this may be less feasible, this is why having good strength is so important, right? You're probably not going to be able to do this straight away because you're just not strong enough. But as you build strength, you'll be able to do these things. There's many things that we will be able to do if we just go through the strengthening process. Pop down like so, and then come back up, right? Whatever it may be. I'm assuming these are small bins, so they're not going to be that heavy, but they are on the floor, as opposed to what's probably been done, which is, there we go, there we go. You don't need to do that, right? If you look at a toddler playing, look at a toddler playing on the floor. They go down and squat. They use their joints. The reason we have bad joints is because we don't use them very often. We don't use them appropriately. Louise said, I was advised to sit in a slightly reclined position as it reduces pressure on the disc. However, this causes a lot of coccyx pain, but it does help the nerve pain when sitting. Is that true? So, what is probably happening is you're not quite sitting in a reclined position correctly. It is true that when we sit with a neutral position in a reclined position like so, we have less pressure on our lumbar spine than in the standing position, which is great. It needs to be reasonably reclined though. What's probably happening, which is why we're getting the coccyx pain, is we're kind of just sitting like so. And we're kind of back a bit, but I'm flexing my lumbar spine. That's most likely what's happening, which means you're hammering in on the L5-S1 disc, aggravating that, which is giving you the coccyx referral. But because the holes at the level of the nerve are larger, you're not necessarily getting the nerve pain. So it means that you're sitting poorly, basically. You can recline with a neutral spine and you can recline with a rounded spine. You're reclining with a rounded spine, which is why you're getting those symptoms, and it needs to be modified. But again, you know, focus on the standing, focus on the rehab work. We've got to focus on the rehab work. What other questions have we got? Guys, I've been going for a little while now, coming into the last 10 minutes. I've covered quite a lot of things here, guys. I do hope it's been very helpful for you guys on this Friday. If you need any more support, those of you that are on TikTok, you can go up to the profile up here, check out the program. Like if you've been struggling, guys, same again on YouTube. If you've been struggling for a long period of time and you haven't been getting better, check out the link in the profile page or the link on in the chat on YouTube after this. Watch the video there. It explains a little bit more about the program. Like you need structure and guidance It helps you up here as well as down there. And you just follow along with it. And that way you get support as well as you're going through the process. If you guys have any questions, you can always ask. Gillian said, I was just diagnosed with spinal stenosis. So this is a great example, right? Because we've then asked, is exercise bike good? This is an example of not being communicated the problem. Gillian, you might, well, you won't be able to because you're on TikTok, but you could scroll back or watch this on YouTube and you'll see my comment to one of the other people that commented about stenosis. If you are suggesting that spinal stenosis is the problem, a closing of this hole, what do? Well, you make it bigger. Duh, right? You just bend forwards. So would that mean that cycling would be good? Yes, it would. But that's wrong. That is wrong. I repeat, just in case Gillian missed it, that is wrong. Spinal stenosis is not your problem. You have some kind of injury in the lumbar spine that is resulting in spinal stenosis. So you can see how it's so confusing for you guys. Because if people are saying you've got stenosis, that's the problem. You're going to do things to make the hole larger because that's all stenosis is. It's a narrowing of the hole. So we can make the hole bigger and hey presto, everything's solved. And it will feel good, by the way. It will. Especially if it's significant stenosis. Hugging those knees is going to feel great. But you realize that you're not solving the problem. Stenosis is there. If we've got a disc bulge, for example, and we start doing those knee hugs, that's sitting on the cycling bike, and we squash down more on the front of this disc, driving this fluid back through the cracked and loosening layers of the annulus fibrosus, creating more damage and stress and strain, feeling nice in the moment, but making the problem worse. That is why this happens. That is why this happens, because we're not understanding the underlying problem, and the problem hasn't been actually communicated. Again, Lou, osteoarthritis is not really a very specific comment. Osteoarthritis, are they saying that the facet joints are enlarged? Are they commenting on this? Generally speaking, they probably just said, you know, oh, well, to help you understand it, it's just osteoarthritis. What's probably happening there is that there is a degree of bulging of the discs or damage to the discs, and there is also a degree of degenerative change to the facet joints, which might or might not include some elements of facet joint hypertrophy. But those degenerative changes, the amount of times that people come in and they go, I've got a back injury. It's been going on for 6 months. Okay, cool. And then they have a bunch of osteoarthritis. Degenerative change, let's call it, because that kind of encapsulates everything on the MRI or on the X-ray. And it's like, you've had the degenerative change for ages, right? Some of you guys will see my knuckle here is enlarged compared to the normal. That is arthritis. Sometimes it hurts because the soft tissues get irritated because I fall on them in jiu-jitsu, and sometimes it doesn't. Degenerative change is, and I think this isn't really communicated enough, we can have degenerative change in the joints and them not be currently irritated. The quality and health of those joints can be degraded, but they might not be currently inflamed. But what that means is for certain, if the hard tissues are showing signs of degenerative change, then the soft tissues certainly are going to be degraded in some way, shape or form. So what do? Improve the health of those tissues. You can't change. Once that bone will forever be larger, and it's probably only going to get larger over time, right? Compared to the others, my little fingers are getting a little bit funny as well from jiu-jitsu as well, right? That's always going to be there. But if I improve the strength, the health, the resilience of the soft tissues around that section of the spine, I can protect it from continual damage. And the osteoarthritis, the degenerative change, is just serving to show that we have repeatedly been insulting this section of our spine. So we need to change something. And that starts with us. No one's going to fix that for us. It starts with us changing those things, becoming educated about the very fact that there is something that we can do, and then starting to do the rehabilitation actions that actually make us better and improve the strength and stability of that area of the lumbar spine so that we can do X, Y, Z every day without getting aggravated. What else? What other questions have we got? Louise, we're focusing on the wrong thing. Focus on the rehab work. Like we're focusing on buying something or having a different chair and this, that, the other. We've got a bad back, and quite a bad one at that. We need to focus on the rehabilitation work. When we're talking about sitting and standing and desk jobs and that kind of stuff, a mixture is the best. Be fidgety is the best. What's a conservative solution for severe spinal stenosis, Diana? Hopefully the stuff I've been talking about has been making sense. The first conservative solution is to stop calling it stenosis and start calling it a problem that is resulting in stenosis. Is it a disc bulge? Is there some facet joint hypertrophy? Are there some ligamentum flavum hypertrophy? The segment is probably irritated, damaged in some way, shape or form. Maybe we've got a spondylolisthesis. I don't know. But that is all going to be encapsulated in a more complete diagnosis. Spinal stenosis is not a diagnosis. Spinal stenosis is an incomplete picture. It's an incomplete comment. It's sometimes a throwaway comment that's given when you go into your GP and they say, oh, you got stenosis, what do you expect? And it's like, okay, what do I do with that? I'll just hug your knees, that'll make the hole bigger. Okay, well, that's not very good advice. Does your back hurt right now? What injuries have you had and what make you credible? go onto the website and have a look. My back does not hurt right now. I'm an osteopath. We've been specializing in the spine over the last over 10 years now, and we've got more details on the website, so you can go check that out. That's what we do. That's what we do. Other questions? I can't walk far without being in a lot of pain. We have a full About Us page on the website, B3. Just coming to the end of the live stream. You guys can check that out. Just send us a DM. We'll send you a link to it. Or you can go on the website and just go to the About section. At the end of the day as well, you know, address the statements. Thinking about it. And also, by the way, just because your back hurt doesn't make, like, there's been a big thing of people on the internet now, like, oh, I had a bad back and now I'm better, so do what I say. Like, that is not good advice. That is not good advice. You might be able to relate to someone, and I understand and appreciate that, but my back hurt and I had a herniated disc and now I'm feeling better is not advice. It does not mean you're qualified to talk about this kind of stuff. And that's an important, like, that's, I know it helps you understand, and the fact that I've had a lumbar spine fracture of the pars at L5S1, L5 specifically, is irrelevant to the comments that I'm making. We've discussed that with members in the past. But just because you've got back pain doesn't qualify you to talk about these kind of things in a way that significantly can help others. That's not to say that it can't. That's not to say that seeing other people's stories can't help. That's not to say that you've got some really helpful things to speak about that may help. But at the same time, one of the reasons that we do these lives is because you just take questions all the time. And you very quickly understand people that can go on a live and talk about this. Like, we've done 500 plus lives. Most of it's been to members. But the fact that you can go on here and talk about it extensively and take these kind of questions and answer them and give what I hope is coherent commentary, that should really help you guys understand the people that can talk about this stuff at length and at detail, and those that, you know, maybe just had a bad back and they can talk about their experience, which is cool, which is great. But yeah, hopefully that makes sense. Lou said, they don't tell me anything. I'm just in the waiting list for nerve ablation. Lou, you've got to do the rehab work. You know, what is the nerve ablation doing? The nerve ablation is essentially trying to disconnect your perception of what's going on down there. And guys, we're coming into the last 5 minutes as well. So if you've got any more questions, please do post them in here. Those kind of procedures, the injections, the nerve ablations, the nerve blocks, they're not dealing with the injury. They're dealing with your perception of the injury. And that's, again, another thing. That's where they're saying the back pain is the problem rather than the back injury is the problem. Is the back extension like Cobra stretch I should do to relieve the lower back pain instead of flexion? No, we focus on spine stability. We actually did a full, KP, send us a DM and say, hey, Mike, can you send me a link to the Cobra podcast? Because we actually discussed this in detail. The Cobra generally, for a lot of people, feels better if you've got disc herniations. However, if you've got an L5S1 issue, sometimes we have things like retrolestheses and a bit of instability shearing backwards, which can make it painful. Additionally, the Cobra is an extension compression movement, meaning we're just compressing backwards, right? And so when we do that, I don't know why people keep requesting weird co-hosting things. When we do that, we make the holes smaller. And if we've got a bit of disc in there, that can pinch the nerves and create irritation. The additional question you need to ask yourself is, how do you know when you're going to be better? Which repetition is it of the Cobra that is going to get you better? Is it rep number 721? Is it rep number 4,000? I don't know. Because the Cobra is doing nothing cumulatively to make you better. Some people might find it feels better. Awesome. Fantastic if you do. But you need to focus on spine stability work to rebuild you. We could say perhaps that the Cobra at best might be something that you do that you feels relieving. And then it would come in the category of relief-based work. But it is not cumulative. I would argue that Cobra probably, if it's painful, would be a reasonable test to do once every so often. And you do one rep. You don't do like 15 reps. You just see if, oh, does back extension still hurt? Yep, still hurts. Okay, we've got to make more progress. But yeah, don't think the Cobra is particularly good. It can be helpful for some. It can feel good for some. But yeah. What else have we got here? I have a disc bulge and herniation. It's not impinging the nerve and I've started rehab and still get the nerve pain. Angela, it depends on where you are in the rehabilitation process. I don't know where you are in the rehabilitation process, in the strengthening process, if you're doing the stuff that we talk about, if you're doing generic exercises. Make no mistake, if you have gone to your physio, your chiro, your GP, whatever it is, and you are given a sheet of exercises, that is not rehabilitation. That is a shopping list of stuff to do, not rehabilitation. Rehabilitation is a process. It is the same exercises done in a different way as you go through that process. It is progressive. And so make sure that you're actually doing rehab, you're not just doing a list of random stuff. Because all too often that is the stuff that you're doing. And equally again, we've got to set expectations, right? You need to understand that you you get that pain relief, you get that improvement in quality of life as a result of moving through the rehabilitation. Moving through, for example, we have the phases, phase 1, 2, 3, and 4 of the program. Going from phase 1 through to 4 is what drives you feeling better because you are objectively building resilience back into that lumbar spine. It is not the fact that you need to wait till you feel better to go from phase 1 to phase 2 or phase 2 to phase 3. You drive the recovery and rehabilitation process by creating the environment that protects the lower back more effectively. Guys, just crossed the hour mark. I'll just have a quick look if there's anything quick I can go through. Thank you. So hard with little direction. It is so hard. But guys, those of you that do need more support, more help, if you're on TikTok, check out the link in the profile page. We've got a link there to the program, backandshipprogram.com. I'll just check I'm a human on here quickly. If you're on YouTube here, if you guys need more help, there's a link in the chat, in the live chat, and there'll be a link afterwards posted in the pinned comment as well. If you've been struggling for a long period of time, you need a little bit more guidance, you need structure, you need a rehabilitation protocol to actually follow. Check out the video on that page, the backandshipprogram.com/start. It explains a little bit more. If you like what you see, if you like the way we do things, if you find these kind of things helpful, then check it out. And B3GR8, no, you do not push through the pain. You do not push through the pain. There are two things that you must always do with your repetitions, with your rehabilitation. Aggravation-free reps, meaning it does not aggravate the symptoms, and some of the symptoms might not be painful, but they should not be aggravated. And if they are, you go back and revisit what you're doing, how you're doing it, because you're probably doing it wrong, and they should be correctly choreographed, meaning the technique is correct. If you're doing those two things, and then you progress through the rehabilitation, that's what you need to do. Hope that really helps you. Reflect on that point, because that is probably the most important thing to have success, aggravation-free with correct choreography as you go through the program, if you're doing spine stability exercises like those we talk about. Thanks, guys. Have a great weekend, and I'll see you next week.